Okay, let me give you a quick patient care scenario. You got a 46-year-old patient with unilateral leg pain, warmth, and swelling, right? You're starting to already think about a DVT, aren't you? The well score is 2. The D-dimer comes back at 600. Now, the question becomes, what does that actually mean clinically? Because this is where a lot of learners make mistakes. Some people see an elevated D-dimer and immediately think, oh, the patient has a clot. Other people get lost trying to memorize cutoffs without understanding why we even use the test. So today, we're going to slow this down and we're going to walk through the actual clinical reasoning, okay? And with that, welcome to This Is Why, a show where we help healthcare professionals transform their medical knowledge from what to why, because that improves the how. Okay? I'm Dr. Busti, and today we're going to approach this exactly like a preceptor would an attending teaching on rounds. So not just what the answer is, but why the answer is the answer. Okay, that's important. And more importantly, right, we want to understand why the wrong answers are sometimes tempting of us, okay? So here's the question. We have a 46-year-old patient who presents with unilateral right lower extremity pain, warmth, and swelling. Yes, deep vein thrombosis or DVT is suspected. Now the patient's 2-level Wells DVT score is 2. A high sensitivity D-dimer, right, came back at 600 nanograms per ml. All right. Compression ultrasonography or ultrasound is available promptly. Okay. What should occur next? A, order a complete blood count or CBC. B, start anticoagulation for confirmed DVT. C, perform compression venous ultrasound of the symptomatic leg. D, repeat the D-dimer to confirm the DVT, okay? Well, the correct answer is C, perform compression ultrasonography of the symptomatic leg, all right? So let's think through this like we're actually seeing the real patient. Now, the first thing is the patient could absolutely have a DVT. Yes, the symptoms fit, unilateral leg swelling, warm, pain, yeah, that should raise concern. But remember, guys, symptoms alone do not always diagnose a DVT. That's one of the first teaching points. Why? Well, because cellulitis can do this. Musculoskeletal injury can do this. Venous insufficiency can do this. And even a ruptured Baker cyst can do this. So clinically suspicious? Yes. Diagnostic? Not necessarily, okay? Now, let's move to that Wells score. The Wells DVT score was 2 in this question. In the 2-level Wells model, that means that the DVT is considered to be likely, right? Now, this is important because likely does not mean confirmed. It means the probability is high enough that we cannot safely just dismiss the possibility. That distinction actually matters because once you understand the pretest probability, the D-dimer starts to make more sense, okay? Now, let's talk about that D-dimer. It came back at 600, and immediately people want to jump straight to one of two bad conclusions. Either they think the patient definitely has a clot, or they start obsessing over that exact number. But neither approach is actually correct. Think about what a D-dimer actually is measuring. It measures that fibrin breakdown. So it tells you that somewhere in the body, clot formation and degradation is occurring, right? But D-dimer is not specific for DVT, and that is key. It can also be elevated in patients with infection, inflammation, cancer, recent surgery, trauma, pregnancy, hospitalization, aging. That's a lot of things. So an elevated D-dimer does not purely diagnose a DVT. It tells you that the DVT has not been fully ruled out. And that is a huge conceptual difference. Okay? And honestly, this is one of the highest yield sort of board concepts in thrombosis in hematologic evaluation. D-dimer is primarily valuable because of its, listen, negative predictive value, meaning when it's negative in the right patient, you can often stop the workup from there. But when it's positive, the workup usually has to continue. That's exactly what is happening here in this question. Now, let's add another detail. The patient is 46 years old. Why does that matter? Because now we don't need to get distracted by age-adjusted D-dimer thresholds, right? So for many board-style questions, the conventional cutoff that most people are familiar with is 500 nanograms per ml, and that is still used, okay? And since this patient is younger than 50, the interpretation stays straightforward in this question. The D-dimer is elevated. The Wells score suggests DVT is likely. So what's the next step? Well, you need objective imaging. That's why compression venous ultrasonography is the correct answer in this question. All right. Now consider the patient that likely is eventually going to sit in front of you, because we don't just answer questions all day. Would you really want to commit somebody, listen, to anticoagulation based only on a mildly elevated D-dimer? Probably not. Anticoagulation is not benign, right? There is bleeding risk. There are medication interactions, and there are procedure implications. So before we label somebody with a DVT and start long-term treatment, we usually want to confirm our suspicion. And that, in this question, is the imaging, and it's promptly available to us. And that detail actually matters, because if imaging were delayed, which is possible, it happens. I mean, I practice in the emergency department. We don't always have ultrasound techs available, or I don't always have access to a good ultrasound to do it. The patient with a high clinical probability, right, may need interim anticoagulation. That may be appropriate while you're waiting, okay? But that's not the situation the question is asking. The question is asking for the next best step when ultrasound is available. And the answer is obviously doing the imaging, not anticoagulation, not repeating the D-dimer, not ordering background labs. Now let's walk through the distractors, because this is where the teaching really begins to happen. You know, look at choice A. It says order a complete blood counter CBC. Now clinically, you eventually want a CBC before anticoagulation. It serves as a baseline. Sure. You may want that hemoglobin and know where they're at. You want to know where their platelets are, right? That's very reasonable. But it does not answer the diagnostic related component of this question. The board exam is asking what you should do next to evaluate suspected, remember, likely concern for DVT. A CBC does not accomplish that. What about choice B? All right, starts anticoagulation because you already have got confirmation, right? The information you've been given is sufficient. Man, this one's dangerous because it sounds very decisive in its wording, but read that wording carefully. The DVT is not confirmed yet. The patient has suspected or likely concerns for DVT. And again, that distinction matters. Why? Because imaging is available and we should confirm that diagnosis, okay? Now, if the STEM had said ultrasound would not be available for many hours and the patient was at high clinical suspicion, we see the same problem in PE concern, then that discussion does change, right? But this STEM intentionally removes that level of ambiguity, right? How about choice D? It says to repeat the D-dimer? Well, this is another classic trap, okay? Repeating a non-specific test does not suddenly make it specific. If the repeat D-dimer comes back elevated again, you still haven't confirmed a DVT, right? And if it comes back lower, now you probably created yourself a level of confusion instead of more clarity. So repeating the D-dimer is not the right move. The correct next move is obviously that imaging. So if you remember one thing from this episode, remember this: D-dimer is mainly a rule out test in the right patient. That's its superpower, if you want to consider it that way. Not ruling in a disease, ruling out disease in the correct clinical setting. That means you always have to connect the D-dimer back to your pretest probability. Low risk patient plus a negative D-dimer, now you may be able to stop, okay? Elevated D-dimer with clinically plausible disease, now you need to continue the evaluation, okay? And in suspected lower extremity DVT, that usually means you're going to do an ultrasound, all right? That is the conceptual flow, okay? And once you understand that flow, you stop memorizing isolated facts and you start understanding the actual clinical reasoning of how you take care of patients. So wrapping this up, a 46-year-old patient presents with symptoms concerning for DVT. That well score is 2, D-dimer 600. The elevated D-dimer does not confirm that DVT, right? It tells us that the workup must continue since compression ultrasound is available promptly. So the next best step is doing that objective imaging and confirming. And that's why the correct answer is doing the ultrasound, okay? Now, if you are preparing for board exams, this is exactly the kind of reasoning pattern that you should be going through faster, obviously, in your mind, instead of just memorizing algorithms. You need to understand why the algorithm exists. That's one of the reasons why I created High Yield Med Reviews. Help you to practice applying this information and core concepts in practice test questions, because unfortunately or fortunately, that's how you pass some of these classes or get your boards, right? So the goal is not simply to just answer the question. The goal is to understand the underlying reasoning well enough that you can apply it to any of the new scenarios, because no one has the exact questions. So you can join for us for free at thisiswhy.health. You can also get discounts over at High Yield Med Reviews through that free membership. Okay, so take advantage of that. Thanks so much for watching This Is Why. I'm Dr. Busti, and keep asking the why, because that improves the how. We'll see you next time.